Welcome back to Deep Dive Ortho. In our world, in orthopedics, there are some injuries that, well, they just carry a profound weight.
They really do.
It's not just their complexity, is it? It's the high stakes.
Absolutely. The stakes for the patient's outcome.
And today, we're undertaking a deep dive into what I think many would consider the absolute apex of upper limb trauma: complex elbow instability.
We are. And these are the injuries that, look, if we don't manage them with anatomical precision and absolute fixation,
It's a guaranteed poor outcome.
it guarantees persistent stiffness, chronic instability, and just a rapid, devastating post-traumatic arthritis.
And for us as surgeons, the mission is crystal clear, isn't it?
It is. We absolutely must restore stability. That's the only way we can allow for immediate active movement.
Because if the joint isn't stable from the get-go,
You simply cannot proceed with a rehabilitation. And that's what prevents the long-term disability. The whole challenge is identifying and treating the precise anatomical lesions that are causing that instability.
Okay, so let's unpack that complexity. Let's start with the classic, shall we? The one everyone knows,
The notorious one.
the terrible triad, a term that's been etched into our lexicon for decades now, since Robert Hotchkiss first defined it back in 1996.
It has. The terrible triad, or TT, is historically the most recognized complex injury pattern.
And for anyone needing a quick refresher, what's that classic trifecta?
It's defined by an elbow dislocation, a fracture of the radial head, and a fracture of the coronoid process.
It's that systematic failure, then.
Exactly. It's a failure under posterolateral displacement forces.
And it certainly earned that formidable name, terrible. Not just because of how it looks on an x-ray, but because historically the functional outcomes were just
Abysmal. They were. Hotchkiss's original work came from seeing this challenging prognosis, the high complication rate, stiffness, instability, and just disappointingly poor results compared to a simple dislocation.
And even now, with modern techniques, it still demands maximum precision.
It does. It really is the archetype of instability from widespread bony and ligamentous failure.
But the terrible triad is just one pathway, isn't it? It's the one that's driven by that posterolateral rotatory displacement.
That's right.
Modern understanding has really highlighted a distinct and I think often more insidious pattern of failure.
Absolutely. And we have to be very clear in distinguishing the terrible triad from what we call varus postremedial rotatory instability, or VPMRI.
A fundamentally different mechanism.
Completely.
Right.
It results from an axial load on the forearm combined with varus and a posteromedial rotational force. So, think of someone falling onto an outstretched arm, but with the forearm pronated.
And that distinction is so critical because while both compromise the joint, they're affecting different buttresses. So what are the defining components of VPMRI?
VPMRI is highly specific. The core components are a fracture of the anteromedial coronoid process, the anteromedial facet, or AMF fracture, and critically, an injury to the lateral collateral ligament complex, the LCL.
So it's that partnership, the AMF fracture and the LCL failure.
That's the one.
And what makes this VPMRI pattern so clinically frustrating, so easy to miss?
It's subtlety. The fracture component, that AMF fragment, it can be deceptively small on standard radiographs.
Right, because of all the overlapping structure.
Exactly. And this high risk of a misdiagnosis leads to catastrophic results. If you manage VPMRI conservatively,
It's a disaster.
you're guaranteeing chronic instability and rapid post-traumatic arthritis. With VPMRI, the burden of proof is always on the surgeon to exclude instability, not the other way around.
That brings us to the absolute central player in both of these patterns, the coronoid process. We often focus on the radial head, but the integrity of the coronoid dictates everything about the joint stability.
Precisely. The coronoid is the anterior buttress of the ulnohumeral joint. Its whole architecture is designed to resist posterior subluxation of the ulna,
Especially as the elbow starts to flex.
particularly beyond about 30 degrees of flexion, yes. Below that, you're relying more on the capsule. But once you start flexing, that coronoid engagement with the trochlea is paramount.
And it's not just an anterior restraint, it plays a massive role in resisting that varus moment in VPMRI.
It's the primary bony buttress against varus stress. Any significant defect there, especially involving that anteromedial facet, just fundamentally compromises the elbow's ability to withstand a varus force.
So whether we're facing a terrible triad or VPMRI, the unifying treatment objective has to be singular.
It is. It's the restoration and maintenance of absolute joint stability. We have to achieve an anatomical reduction and secure fixation.
Because only then can we start the really crucial next step.
Early active mobilization. Any prolonged immobilization is a direct path to the dreaded stiffness that plagues these outcomes. Stability is the foundation. Early movement is the building.
That's a robust foundation. Let's move into the mechanics now, drilling down into the detailed anatomy, because this is where surgical strategy really begins.
It is. If we're thinking in pure biomechanical terms, we divide stability into static and dynamic stabilizers.
And the bony architecture itself provides a huge amount of that static stability.
A huge amount, up to 50%, some estimate. It's that highly congruent ulnohumeral articulation. It's like a tight interlocking hinge. That's the main bony constraint.
So you have the bony fit, and then you layer on the primary ligaments.
That's right, the primary static stabilizers. On the medial side, the key player is the anterior bundle of the medial collateral ligament, the MCL.
The main restraint to valgus stress.
It is the non-negotiable restraint to valgus, and it's doing most of its work. It's peak loading, right in that functional arc of motion.
So between about 70 and 120 degrees of flexion.
That's the one.
And then laterally, we turn to the structure that really dictates that whole terrible triad sequence.
The lateral ulnar collateral ligament complex, the LUCL. That is the primary restraint to posterolateral rotatory instability, or PLRI.
So its failure is the first domino to fall.
It's the prerequisite. Its failure allows the ulna and radial head to rotate externally and sublux posteriorly. That's the mechanism that starts the terrible triad.
This idea of the instability sequence, the circle of Jorge, is so important here. It's a progression of failure from the outside in.
It is. The trauma starts with failure of the lateral structures, the LUCL. If the force continues, it propagates anteriorly and posteriorly through the capsule and then potentially to the medial side, the MCL.
Which results in the full terrible triad.
Exactly. It's rare to get medial failure without that prior lateral compromise, unless you have that dominant varus rotational force we see in VPMRI.
So if the MCL and LUCL are the primary restraints, where does the radial head fit into this stability picture?
The radial head is the key secondary static stabilizer.
Sometimes overlooked, but vital.
It is vital, particularly when the primary stabilizers are injured. It acts as an anterior buttress and a critical stabilizer against valgus stress.
And its role changes throughout the arc of movement.
Significantly. In extension, it contributes very little. But as the elbow flexes, say between 20 and 120 degrees, its articulation with the capitellum resists displacement.
Which is why if you lose the radial,
you automatically increase the stress on the MCL, and you lose that anterior bony restraint. That is why anatomical reconstruction or replacement of the radial head is completely non-negotiable in the terrible triad.
Let's go back to the coronoid. These fractures are really bony avulsions of ligament attachments, which is why the location is so important.
That anatomical detail is paramount for planning. We're not just fixing bone, we are reconstructing a ligamentous tension band.
Okay, so let's walk through those attachments proximally.
Proximally, the anterior joint capsule attaches very close to the tip, about 6 millimeters distal to the tip.
And for small type I fractures, repairing that capsule is often enough.
Often, yes. Then, distally and medially, you have the critical attachment, the anterior bundle of the MCL.
Right, onto the sublime tubercle.
The sublime tubercle, which sits about 18 millimeters distal to the coronoid tip.
That 18 millimeter mark is fascinating because it means any fracture extending beyond, 20 or 25% of the coronoid height immediately puts that primary valgus stabilizer at risk.
Exactly. Fractures involving the sublime tubercle are fundamentally compromised medially, regardless of the LCL. If you fail to address that attachment, you're guaranteeing residual instability.
And finally, there's the muscular pull.
The brachialis. It is a broad, powerful insertion anteriorly near the base of the coronoid.
And that acts as a major deforming force.
A huge deforming force on those larger basal coronoid fragments. For type 3 fractures, the brachialis pull makes achieving and holding reduction particularly difficult. It often demands a strong buttress plate.
Understanding that anatomy leads us straight to the language we use to describe these. Let's shift to classification systems and diagnostics. We have to start with the old standard, Reagan and Mori.
The Reagan and Mori, or RM classification, it's the traditional workhorse. It's based on a simple measurement, the fracture height you can see on a lateral X-ray.
Just a quick recap of the three types.
Type I is a simple tip fracture, the capsular avulsion. Type 2 involves up to 50% of the coronoid height. And type 3 is more than 50%. Often extending to the base.
Now, it's universally understood, but RM has some pretty significant limitations in modern trauma management.
It really does. While a type 2 or 3 clearly signals instability, the RM system completely fails to address the rotational component,
Or the specific location of the fracture.
which is the key determinant in VPMRI. It doesn't tell you where along the circumference that fragment came from.
And that's where Driscoll's work just revolutionized the approach. He moved us beyond simple height to mechanism and morphology.
Precisely. The O'Driscoll classification is morphologically driven. It correlates the fracture location with the traumatic force. And critically, it recognized the specific pattern of the anteromedial facet, or AMF, fractures,
Those type 2 fractures.
which are pathognomonic of that varus posteromedial rotational mechanism. It separates them entirely from the PLRI-driven terrible triad.
Let's detail those type 2 subtypes, because the difference between them is functionally profound for the surgeon.
It is. Subtype 1 is an isolated fracture of the AMF surface. Subtype 2 involves the AMF surface plus the tip of the coronoid. So that's more energy, loss of the capsule attachment.
And then the critical one, subtype 3.
This is the complex lesion. It involves the AMF, the sublime tubercle, and an extension to the coronoid tip.
The true surgical nightmare.
Because by involving the sublime tubercle, it means the primary valgus restraint, the anterior bundle of the MCL, is functionally avulsed with that fragment.
So a subtype 3 injury immediately means you're not just fixing bone, you're reconstructing the entire medial stabilizing complex.
That's it. The shift from a subtype 2 to a subtype 3 is a transition from fixing a buttress to reconstructing the whole medial side.
Now, diagnostically, we all know the limitations of 2D x-rays. We routinely jump straight to CT for preoperative planning.
It's the standard of care. A high-quality CT scan is mandatory to fully characterize the pattern, the comminution, the displacement. A small AMF fragment can be so easily obscured.
But even a standard CT can have its limits. And this is where the advanced technique of 3D CT reconstruction with humeral subtraction comes in. Can you explain the value of this?
This technique is, frankly, a game changer for these AMF injuries.
Oh, so?
Well, the fundamental problem is that the trochlea overlaps the AMF fragment, so you can't really assess the true articulation. Humeral subtraction is a digital process where the computer virtually removes the humerus from the 3D reconstruction.
So you're left looking directly at the articulating surface of the ulna, completely unobstructed.
Precisely. You can visualize the coronoid fracture through the articular surface of the sigmoid notch. It gives you this immediate, clear view of the injury that reflects the impaction mechanism.
And what specific features are you hunting for with that subtraction view that scream VPMRI?
We're looking for two key things. First, the AMF fragment often has a characteristic concavity.
Right, the imprint left by the trochlea.
It's the direct imprint. And second, we can confirm the fracture orientation has that medial obliquity extending towards the sublime tubercle, which confirms the trajectory of the avulsion force.
And how much does this improve clinical reliability?
Substantially. It's been proven. Studies show that adding the humeral subtraction view dramatically improves inter-observer agreement.
Which is crucial for standardizing treatment.
It is. The Kappa score, a measure of agreement for characterizing morphology, improved from a fair 0.28 to a substantial 0.66 when the subtraction view was included.
That jump from fair to substantial is powerful. It really reduces the subjectivity in diagnosis.
It standardizes the language. When a colleague says they have an AMF fracture on subtraction CT with concavity and medial obliquity, we know exactly the mechanism, the likely instability, and the surgical challenges ahead.
Okay, let's pivot to the critical debates in surgical management. Having diagnosed the injury, the surgical threshold is the next hurdle. You mentioned instability is the trigger, not size. But for VPMRI, we do have concrete cutoffs.
We do. While stability is paramount, in VPMRI, that AMF fracture is intrinsically linked to instability. The consensus for surgery is firm. Any coronoid fragment surpassing 2.5 millimeters in height, or constituting more than 15% of the total coronoid height, that mandates intervention.
And that 2.5 millimeter and 15% rule is pretty robust.
It is. It's based on the understanding that fragments bigger than that significantly compromise the bony buttress. Below that, you might trial conservative management, but exceeding it strongly contraindicates it.
Yeah.
The risk of chronic instability is just too high.
Right. So moving into the theater, the choice of surgical approach dictates everything. Historically, we saw these large posterior approaches.
We did. And they have major drawbacks. Extensive soft tissue dissection, high risk of ulnar nerve injury, heterotopic ossification. and profound stiffness.
So the modern trend is towards more targeted, combined approaches.
Exactly. Let's focus on the medial approaches needed for these AMF fractures. We often weigh the Hotchkiss versus the FCU split approach.
And the choice depends on the O'Driscoll subtype.
Entirely. The Hotchkiss approach is excellent for type I and type II tib fractures. It gives you great exposure there, but it often provides insufficient access to the sublime tubercle.
Which means for that complex type 2 subtype 3, you need the FCU split.
Precisely. The FCU split approach gives you a significantly broader exposure of the medial side, superior access to the sublime tubercle. Since a subtype 3 involves the MCL attachment, that enhanced view is critical for anatomical reduction and fixation.
What about the increasingly popular anterior approach? Proponents argue for its direct access to the coronoid.
And the theoretical advantages are compelling. Direct visualization, you minimize damage to the flexor group, you avoid the ulnar nerve risk.
But the execution is key. The interval choice is crucial.
Absolutely critical. Technical studies now advocate using the interspace between the brachial artery and the median nerve, the BM interval.
And that gives you much better access.
Significantly greater exposure. One study quantified it as 2.26 times greater access. But we must remember, the anterior approach makes addressing the LCL and MCL through a single incision nearly impossible.
Which leads us to the preference for combined protocols.
Yes. The trend is a combined approach tailored to the pathology. So, address the lateral structures, radial head, LCL, through a posterolateral approach, like a coacher. Then, once you have lateral stability, you use a specific anteromedial approach to fix the coronoid.
And that's been shown to reduce surgical time.
It has. Reduced surgical time and shorter hospital stays compared to those big posterior incisions.
Okay, so we're in. The biomechanical data has to guide our fixation. Let's start small, the RM type I tips.
For these small capsular avulsions, it's usually not absorbable sutures, suture anchors, or the lasso suture technique.
Transosseous fixation.
Yes, and it's been shown biomechanically to restore enough stability to allow immediate active motion.
But when we move to the larger RM type 2 fragments, the choice between suture and rigid screw fixation is paramount. And the biomechanics strongly favor rigidity.
Without question. The quantitative data here is invaluable. A cadaveric study compared fixation of simulated RM type 2 fractures. One group got a screw, the other a suture lasso.
And the difference was striking.
It was. The mean load to failure for screw fixation was around 405 newtons.
405. Okay, and the suture lasso.
It failed at a mean load of only 207 newtons.
Wow. So that's almost half.
It's practically double the strength for the screw construct. It's a huge difference.
And what does that 200 Newton difference really mean in a clinical setting with early active mobilization?
It's significant. Early active mobilization puts cyclical low-level stress on the repair. The analysis showed the lasso technique didn't fail from the suture breaking, but from the soft, cancellous bone yielding. The suture just pulled through the fragment,
causing a loss of reduction.
a subtle but disastrous loss of reduction. The screw, on the other hand, provides rigid compression and buttressing. It allows the construct to withstand those functional forces.
So any type 2 fragment big enough for a screw gets a screw.
It's an absolute indication for rigid internal fixation.
Now let's move to the O'Driscoll type 2 and a 3 AMF fractures. Here, the gold standard shifts again, this time favoring plating over isolated screws.
For these AMF fractures, especially the subtype 3 involving the sublime tubercle, the evidence strongly mandates buttress plating. Isolated screws just don't provide the anti-shear and anti-rotation stability you need.
What does the data tell us when comparing screws versus plates here?
Well, biomechanical testing showed that screw-only constructs provided inferior stability, failing at an average of only 316 newtons.
316. And with a plate?
With a plate, it was dramatically different. Plated constructs, especially locking plates, achieved maximum loads to failure around 650 newtons.
650. That demonstrates the plate's absolute necessity as a buttress.
It's the plate acting as a tension band and a true buttress that prevents displacement. Relying on an isolated screw here risks catastrophic failure.
We should also touch on innovative approaches, adapting hardware for the coronoid's tricky shape.
Certainly, it's an irregularly shaped bone. We're seeing more use of non-conventional osteosynthesis, adapting small fragment plates, even metacarpal plates, to get a precise anatomical reduction.
Because perfect reduction is non-negotiable. Non-negotiable. Finally, in this section, the LCL dilemma in VPMRI. If you achieve a rock-solid coronoid fixation, is repairing the LCL always necessary?
The standard protocol is clear. Fix the radial head, fix the coronoid, and repair the LCL.
But there is a debate.
There is. It arises when a highly rigid coronoid fixation appears to restore overall stability completely. Some clinical series suggest functional outcomes can be satisfactory, even with non-repair of the LCL, if the joint is stable intraoperatively.
So what are the criteria for skipping an LCL repair? It seems risky.
It's controversial, and it hinges on dynamic intraoperative stability testing. If, after bony fixation, the elbow is stable through the full arc of motion, particularly into extension and supination,
Then some might defer it.
some might, yes, but it remains the exception, not the rule. The standard approach is to address the LCL, then check the MPL only if there's residual instability.
That brings us to the final essential stage, postoperative care and rehabilitation. If the fixation is sound, the war against stiffness begins immediately.
Absolutely. Post-op management is relentlessly focused on mitigating stiffness. It's the single most common complication. The quality of the surgery is defined by the quality of the rehab it permits.
Let's detail the initial immobilization protocol.
It's non-negotiable and specific. The elbow is immobilized in 90 degrees of flexion with the forearm in pronation.
In pronation, why is that so important?
It is crucial. Pronation tensions the lateral structures, specifically the LCL complex. By keeping the forearm pronated, you safeguard the LCL repair and prevent the ulna from externally rotating.
And you'd initially restrict terminal extension?
Yes, typically the terminal 30 degrees, as the elbow is most unstable closer to full extension.
And the urgency for mobilization can't be overstated. What's the timeline for starting active ROM?
As quickly as stability allows. Ideally within 48 hours or certainly on post-op day 2 or 3, we know that immobilization beyond 3 weeks leads to universally poor functional results.
So how does that rehab progress over the first few months?
It's incremental, guided by the surgeon and the physio. The arc might be tightly controlled at first, say 60 to 110 degrees of flexion, then it's gradually opened up.
With the ultimate goal being that functional arc of motion.
30 degrees of extension to 130 degrees of flexion. It requires diligent physiotherapy, often for 6 to 12 months, for a near-complete recovery.
Now, complications. Stiffness is common, but what are the other major concerns we have to mitigate?
Beyond loss of motion, it's post-traumatic arthritis, recurrent instability, so fixation failure, and heterotopic ossification, HO.
And HO is a particular concern after this level of trauma and surgery. How do we mitigate that risk?
We use prophylactic measures. A standard evidence-based protocol is often prophylactic NSAIDs. For example, celecoxib, 200 milligrams twice a day for 3 weeks post-op.
To inhibit that inflammatory cascade.
Exactly. It inhibits the cascade that drives ectopic bone formation.
And before we conclude, what about arthroscopy? Is it becoming a true alternative for some of these fractures?
It has emerged as a viable alternative for highly selected cases. The advantages are clear. Less surgical trauma, less fibrosis, potentially lower complication rates.
But the constraints are significant.
They are. Its application is severely limited by fragment size and comminution. It's generally not suitable for large basal type 3 fractures or highly comminuted AMF injuries. It's a finesse technique for smaller, well-defined fragments.
Finally, then, from the patient's perspective, with these modern protocols, what functional results can we realistically expect now?
The prognosis has vastly improved. When we adhere to these principles, anatomical reduction, absolute stability, early motion, the reported functional outcomes are excellent.
So what does that look like in terms of scores?
Mia Mayo elbow performance scores, the MEPS, now frequently exceed 90 points. We're seeing series where patients 2 years post-surgery are achieving a Mayo score of 100.
Which is almost complete functional recovery.
It is. The terrible triad is still a challenge, but modern surgical science has certainly diminished the terrible component of its name.
That is a powerful and hopeful note. Today, we have navigated the complex world of elbow instability, distinguishing the terrible triad from the rotational failure of VPMRI. We underscored the non-negotiable role of the coronoid and detailed the shift from the size-based Reagan-Mori system to the morphological O'Driscoll system.
A system that's been so refined by 3D CT with humeral subtraction. We've also emphasized that shift in surgical strategy, moving towards these tailored, less traumatic combined approaches and reinforcing that decision-making has to be evidence-based.
Especially regarding the biomechanical superiority of rigid fixation, particularly buttress plating for those critical AMF fractures. If you found this discussion valuable in refining your clinical practice, please take a moment to rate and share this deep dive with a colleague. So as we conclude, What final provocative thought should we leave our listeners with on the future of managing these intricate injuries?
We've achieved excellent mechanical stability with better hardware and techniques. But the true future challenge isn't just in surgical technique. It's in whether advanced imaging, like 3D CT with humeral subtraction, can help us develop a fracture categorization based on morphology that is so precise, so universally agreed upon, that it finally allows us to standardize treatment algorithms globally.
To minimize both under and over treatment.
Exactly. The final frontier is definitive algorithmic certainty.